Thank you very much for the invitation. I greatly appreciate to be here. And my presentation will be about evidence-based simulation and interventional endoscopy. These are my disclosures. I'm sure that you can read this. I use the same slide when I give this presentation in Western countries. And most people cannot read this, but some Americans can understand primum non nocere, which means above all, do no harm. That's what it's all about. In medicine, we want to help patients, but we don't want to cause any harm. And this is defined as the... Thank you, Floristo. Yeah. And that's the goal of simulation, is to improve the safety of our procedures. We learn things differently. Some of us like to look at pictures. Some of us like to listen to lectures. Some of us want to watch a videotape. So we learn things audio, visually, or some learn more with tactile feedback. Some try to understand the whole picture first before going into details. Other learners try to learn A, B, C, and then understand the whole pictures. These different type of learning models have been described by Felder and Silverman. The advantage of simulator training is that it accommodates various channels, visual, auditory, and tactile, and that's why simulator training is so effective. The potential of simulator training was also identified by Harvard Medical School, where I work, and simulated training has been incorporated into medical student training early in medical school, actually going through every year 1, 2, 3, and 4. Every year, medical students commonly work in a simulation suite. Also in the hospital, we could show that simulator training improves the performance of physicians. Here you can see a simulation suite at Beth Israel Deaconess Medical Center, a patient room that's entirely used for simulations. As well here, a surgical arcade of current surgical simulators, and a conference room that's only used for simulations. The same at Boston Children's Hospital, where I work. We have a simulator suite in the intensive care unit right next to patient rooms, and the team participates in simulations twice a week. So during clinical care, the team will, if time allows, will go and do a simulation as part of the general practice. The background of simulation is that simulator training was first used for U.S. pilots, and the U.S. Army could show that with simulator training, the amount of crashes was reduced. The same then happened for the commercial airline pilots, that is now becoming a standard education module for pilots. In GI, it started in the 70s as well. Claassen and Rupin developed the first plastic model, and then Christopher Williams developed another plastic model, which has been used for quite a while. This is the Interfan model from Professor Grün from Tübingen in Germany, also an artificial tissue model. And these are the computer simulators that many of you have used already. The first one was the ReSimulator, developed in 91. Then the GI Mentor, which is widely distributed, developed in 97. And the other one is the Immersion AccuTouch Simulator. When we look at simulators, we want to make sure that they actually train us something that's useful for the patients. So there's different tools of assessing a simulator, and it's important to review this slide, and I apologize for the small font size, but one validity testing is the face validity. It's usually participants who use a simulator rate how good they think a simulator is. They say, well, this is a good one or it's not a good one. That's face validity. Then content validity is something that is assessed by experts, and they decide whether the simulator actually tests something that is useful for a clinical practice. Then there's construct validity, which means that the simulator can differentiate between beginners and experts. That means a novice will perform more poorly than an expert on the simulator. But what we're mostly interested in is criterion validity, which means that when you learn on a simulator, you'll actually do better in your patients. And that requires the comparison of the simulator data with patient-based data. So that's the holy grail of simulator testing. There's an interesting paper that Ansel and colleagues published in 2012 looking at the validity of colonoscopy simulators. And I'm going to speak with this slide about colonoscopy simulators because the evidence of upper GI models is relatively limited. So most of the studies focused on colonoscopy simulators if we're talking about virtual reality. And the authors state that the majority of evidence at present is demonstrating the construct validity and some evidence about face and content validity of virtual reality simulators. However, there's no evidence demonstrating the criterion validity for virtual reality models, which means there's limited data comparing the performance of physicians on the simulator with actual clinical performance. And that's something that's currently still needed for virtual reality models. Live animal courses have been performed since the 1990s. Golson and colleagues introduced those in the 90s. The advantage of using a live animal is that you have a similar anatomy, especially using the porcine species. You have perfused tissue with natural elasticity, and the mucosa is realistic that allows you to simulate procedures such as EMR and ESD. The disadvantage, though, is that it is limited to special training facilities that allow the use of animals and also the capabilities to put the animals under anesthesia. There's ethical concerns with using pigs because after a procedure you have to sacrifice the pig. NPO preparation is quite difficult. The pigs also have a long snout, which makes procedures with regular gastroscopes relatively difficult. And also, most importantly, the pigs, they don't have any diseases. They're usually normal and don't have any pathology. The reason we have developed the EASY simulator is to overcome some of the disadvantages of live animal models. So we developed the EASY simulator, which uses a stomach and the esophagus from the pig, and we sutured in artificial vessels into the wall to simulate a spurting arterial bleed here, for example, for the simulation of endoscopic hemostasis. So this simulator has been around for quite a while, since '97. And we wanted to look at the effectiveness of the simulator. So we conducted a prospective randomized double-blinded study comparing the performance of fellows, GI fellows that are trained on the model with fellows that are trained in the hospital in endoscopic hemostasis. You can see the standard group was trained regularly in the hospital, and the intensive group received 3 workshops of simulator training over 7 months. And this was in the area of New York, involving 14 hospitals and about 50, 60 physicians. So the techniques that we trained the fellows in was manual skills, a simple test where they had to poke at 4 dots at the anterior wall of the stomach and form a circle through those dots. Then injection and bipolar electrocoagulation of a Forest 1A ulcer bleed, hemoclip application, and variceal band ligation. And here you can see that part of this course was faculty, international faculty. Here C.J. Gustaud from the Mayo Clinic served as a blinded evaluator. We had 2 fellows to 1 instructor, 30 to 45-minute training blocks. We also taught the fellows on how to set up the devices. We provided hands-on practice questions and feedback, and then evaluations before and after each training unit. The final evaluation was blinded. You can see a short video clip that kind of describes how the training occurred. Here's Professor Gustaud from the Mayo Clinic. Yeah. This audio is not meant to be there. Okay, that's better. Well, you saw the fellow being trained in injection and coagulation, and here you can see the results from the New York project. On the right side, the EASY training group that had the simulator training, the group improved significantly in all 4 techniques. The standard group improved significantly only in variceal band ligation. For the first time, we were able to demonstrate learning curves of various techniques, and we found that techniques like band ligation can be acquired relatively quickly. One workshop is enough to become proficient, and that level can be maintained. However, other techniques such as hemoclip application required several workshops to get really good. So that's important to know that for some techniques, one workshop is not enough. You have to train actually a little bit more. And most importantly, we looked at the clinical cases of the fellows during the study period. So we looked at how they performed, and we could show that the intensive training group less frequently required the intervention of the attending physician. The hemostasis time was comparable. However, the hemostasis was more successful in the intensive training group in comparison to the control group, and the complication rate was lower. So that's, for the first time, we could show an evidence of simulator training for the clinical performance. And we performed a repeat study in France, a national training project, which Professor Koumaros was, for example, part of this as well. And here you can see the study group. And we can compare the results of the New York fellows with the results of the French fellows, and we could see that those results were reproducible. Here for manual skills, a similar increase in performance over time. New York on the right side, France on the left. For injection and coagulation, you can see that the French fellows did a little bit better than the New York fellows over time. For hemoclip application, the increase in performance was comparable, as well as for variceal band ligation. The EASY simulator has been more refined and developed to facilitate other techniques as well, such as laparoscopy, single incision laparoscopic surgery, transanal endoscopic microsurgery, and nodes. Here, this is just a short video that shows the advantages of a real tissue simulator. You can see the haptics of cutting through real tissue is very realistic, similar to a patient. And when you make the incision here, you can use the endoscope to go through the stomach wall into the peritoneal cavity. We're currently conducting an NIH-funded study with $2.7 million of funding to develop a virtual reality simulator. We look at the performance of experts and beginners in nodes in the simulator and then track the motion on how they perform these tasks. And based on that data, the Rensselaer Institute, these are the computer experts, then create this virtual reality environment for nodes. And here you can see that virtual reality node simulator being used. The purpose of this is to investigate new potential indications of nodes. The impact of the studies that we have conducted on the training of physicians, it can be explained by the example that the ASGE drew some significant consequences of the studies that we have conducted. They have developed this IT&T center in Chicago, a multi-million-dollar investment where physicians are trained using ex vivo models as well as live models in interventional procedures. In fact, GI fellows from all over the country travel to Chicago to get trained there, in addition to attendings who learn new procedures. The summary of my presentation is that the face, construct, and content validity of virtual reality simulator has been demonstrated, but there's limited evidence about criteria and validity for virtual reality simulators. Ex vivo simulator training has been shown to improve patient outcome in the field of endoscopic hemostasis. And the impact from that study is that the ASGE is implementing simulator training in the education of fellows and attendings nationally. And potentially the use of simulators will become important for the credentialing of new procedures. Thank you so much.
Thank you, Prof. Matthes. Very